Now, asthma is a chronic inflammatory disorder of the lung airways. It is characterized by intermittent airflow obstruction, which is usually reversible. It could be either spontaneous or with treatment. Whereas on the other hand, COPD is a progressive lung disease, and it is characterized by persistent airflow obstruction with little or no reversibility. If we talk about the age of onset, asthma is usually observed at a younger age, while COPD mostly occurs after the age of 40, but other reasons could also contribute to the onset of COPD before the age of 40. Some symptoms may be the same in both the diseases, like wheezing, chest tightness, shortness of breath, exercisal intolerance, and anxiety with increased heart rate. But what makes asthma different from COPD is that cough caused by chronic airway inflammation, symptoms often worsen at night or early in the morning. And symptoms show variations over minutes, hours, or days. Whereas in the case of COPD, the ongoing mucus production or mucus-producing cough, also known as smoker's cough, these symptoms are usually persistent, and chronic cough and dyspnea may be observed. You can say that asthma shows symptoms in response to any triggers or may be seasonal, whereas in contrast, the symptoms of COPD slowly get worsened with the passage of time, even without a trigger, as it is progressive in nature. Genetic patterns influence both of these diseases. Maternal smoking can be a factor in both conditions as well, and certain drugs like beta blockers can exacerbate both. Now, if we talk about asthma particularly, allergens like house dust mite, flower, or animal dander can even be a cause. Or there could be a previous history of rhinitis, eczema, eosinophilia may also be a risk factor. In the case of COPD, though smoking can be a precipitating factor in asthma, but most encountered risk factor for developing COPD is tobacco smoke. And it is estimated that 80% of patients with COPD have a significant smoking history. Another reason could be aging, emphysema, BPD, which is bronchopulmonary dysplasia. It is a form of a chronic lung disease that affects newborns particularly. Now, other environmental factors like air pollution may also influence the disease. And as we have seen in recent times, due to a viral infection, specifically I'm talking about coronavirus, can result to development of COPD in the patient. Although COPD and asthma both involve inflammation in the respiratory tract, now there are marked differences in the nature of this inflammatory process. Asthma involves inflammation of all airways, but without involvement of the lung parenchyma. While in COPD, there is a predominant involvement of the bronchioles and the lung parenchyma. Now, each of these invoke different immune responses as well. Now, asthma is characterized predominantly by type 2 inflammation that is triggered by an allergen, mostly. Now, the reaction of the body may involve eosinophils, CD4 T lymphocytes, and mast cells, and they all result in variable bronchoconstriction and airway hyperresponsiveness. Edema of the mucus lining could be observed in the small bronchi, and plugging of the bronchial lumen with viscous mucus and inflammatory cells may be observed. Whereas in COPD, it is mainly characterized by neutrophilic inflammation that is triggered mostly by cigarette smoke, or like I told you earlier, it could be a viral infection. The cells involved in the response are CD8 T lymphocytes, neutrophils, and macrophages. Now, these lead to slowly progressive airflow limitations due to fibrosis and alveolar destruction. Spirometry can be done to diagnose both of these disorders. Now, specifically talking about asthma, FeNO test may sometimes be administered. Now, FeNO stands for fractional exhaled nitric oxide test. Now, this test measures the amount of nitric oxide in your breath, and it helps doctors tell how much inflammation you have in your airways. A peak flow test may also be done in some cases. And talking about COPD, usually chest X-ray or CT scan may be administered, or blood tests may be done to rule out differential diagnoses like anemia or to detect alpha-1 antitrypsin deficiency, which is a quite rare genetic deficiency that increases COPD risk. If we talk about the treatment of both these diseases, well, the combination of long-acting beta agonists or LABA and inhaled steroids is useful in both conditions. And short-acting beta agonists should be used intermittently in asthma but may be used regularly or combined with anticholinergic in COPD. Now, anticholinergics seem to yield the best results in COPD, but some patients with asthma may also benefit from their use. Leukotriene receptor antagonists and type 4 phosphodiesterase inhibitors in asthma and COPD patients may also be administered. Tiotropium may be the most effective agent as monotherapy in COPD. Long-acting bronchodilators are effective agents as monotherapy in COPD as well. But in asthma, they should be combined with a controller medication. And remember that in the case of COPD, you have to diagnose and treat the underlying condition which is actually causing the COPD. So that is very important. Now, if we talk about the life expectancy of these patients, now asthmatic patients mostly have normal lifespan if they avoid the triggers and if they continue treatment. While studies have shown that a decrease in lifespan of COPD over time may be observed if treatment is not given appropriately. I hope the confusions between these two diseases are a bit clear now. For more such videos, keep watching sqadia.com.